Welcome to The Explainer. Today, we're diving into a condition you are definitely going to see in the clinic or the ED, but you might not recognize it at first. Cyclic Vomiting Syndrome, or CVS. Let's get you ready to spot it.
Okay, so let's jump right in. You might be thinking, cyclic vomiting syndrome, that's gotta be rare, right? Well, check this out. A whopping 2% of the US population has it. That makes it way more common than a lot of things we routinely look for, and yet it gets missed all the time. And this right here really gets to the heart of the problem. For the person living with this, it's not just a diagnostic puzzle, it's a years-long nightmare. Imagine being bounced from one specialist to another, going through all kinds of expensive, pointless tests, sometimes even getting unnecessary surgeries, all because nobody recognized the fundamental pattern. All right, so here's our game plan. We're going to talk about why it's missed so often, how you can recognize the classic pattern, nail down the diagnosis, and then, of course, how to treat it. We'll wrap it all up with the key takeaways you need to know. First up, let's really dig into this idea of a common but missed diagnosis and what that actually means for the people affected by it. And look, the stakes here are just incredibly high. We're talking 1 in 3 adults with CVS becoming disabled by it. 50%, half of them, are in the emergency department at least once a year. Just think about that. Spotting this early isn't just some academic exercise. It's how you stop this whole cascade and actually give someone their life back. Okay, so if there's one thing you take away about diagnosis, it's this. You have to learn to see the pattern. It's not just about the symptoms, it's all about recognizing the cycle. If you can see the cycle, you can make the diagnosis. So what exactly is CVS? Let's get a clear definition. This isn't just random recurrent vomiting. It's a disorder of the gut-brain axis. And the 2 magic words you need to remember here are stereotypical and episode-free. For each patient, the attacks are almost identical every single time. And just as important, in between these attacks, they feel perfectly fine. Recognizing these 4 phases is everything. You've got the inter-episodic phase, when the patient feels totally normal. Then comes the prodrome, which is like a warning sign. Then bam, the emetic phase hits with that intense vomiting. And finally, the recovery. Understanding this is key because how you treat them is totally different depending on which phase they're in. So when you're taking a history, what are the breadcrumbs you should be looking for? You gotta ask, is it the same exact thing every time? Do you get a warning sign? Some people even describe this feeling of impending doom. Don't get thrown off by abdominal pain. Most patients have it. And always ask about timing and triggers. Those early morning attacks, classic. Okay, let's talk about a huge clinical pearl, or maybe it's more of a clinical trap you need to avoid. You hear a patient talk about taking compulsive hot showers, and your brain immediately screams cannabinoid hyperemesis syndrome. But hold on, almost half of CVS patients who don't even use cannabis do the exact same thing for relief. It's a clue, for sure, but it does not seal the deal for CHS. All right, so you're seeing the pattern, you're thinking CVS. Now what? How do you lock in that diagnosis? Well, the good news is it's actually pretty straightforward. It's all about using the right criteria and, just as important, knowing when to stop investigating. This is your diagnostic toolkit right here, the Rome 4 criteria. You can literally pull this up and use it as a checklist with your patient. Are the episodes stereotypical? Do they happen often enough? And critically, are there clear breaks in between where they feel well? A history of migraines in them or their family is also a really strong supportive clue. And this is so important. The workup needs to be limited. You do it once, at the beginning, to rule out the big scary stuff like an obstruction, and then you stop. Seriously, repeatedly scoping a patient who fits this classic pattern is usually pointless and just adds to their medical trauma. And that brings us to the main event, the question that trips everyone up. Is this CVS, or is it cannabinoid hyperemia syndrome? Look, the number one way to tell these two apart is the timeline. It all comes down to one simple question. Which came first, the heavy cannabis use or the vomiting? With CHS, the cannabis use precedes the symptoms. With CVS, a lot of patients actually start using cannabis after the vomiting begins, trying to find some relief. And the ultimate test? CHS gets better when you stop cannabis for a long time. CVS doesn't. Okay, let's switch gears to treatment. And the great thing about managing CVS is that it's super logical. It all depends on 2 things: how severe the patient's disease is and what phase they're currently in. So this right here is your first big decision.
You have to figure out, is this mild CVS or is it moderate to severe? Because that one question changes your entire treatment plan. If it's mild, infrequent, short episodes, no trips to the ER, you just focus on abortive meds to stop attacks. But if it's more severe, you need to add daily prophylactic meds to prevent them from happening in the first place.
So for those folks who are really suffering, the ones with moderate to severe disease, our goal is prevention. And the guidelines are pretty clear. Tricyclic antidepressants like amitriptyline are your go-to first-line choice. The trick is to start low and go slow, titrating the dose up every couple of weeks.
Okay, now for abortive therapy. This is for all patients, and it's about stopping an attack right in its tracks. And what's the common theme here? The route. When someone is that nauseous or already vomiting, a pill is just not going to work. You have to think non-oral, intranasal sprays, shots, or sublingual tabs that dissolve under the tongue. And if there is one thing you teach your patient, one thing, it's this. Timing is everything. You have to drill this into them. You need to recognize your personal warning sign, your prodrome, and take your abortive medicine the second you feel it coming on. If they wait until the vomiting starts, it's usually too late.
All right, let's bring it all home. We're going to do a quick, high-yield summary. This is the stuff you absolutely need to have in your back pocket on the wards.
So if your brain is full and you can only remember 5 things, make it these 5. 1. Think CVS. Have a high suspicion. 2. See the pattern. Those 4 phases are your guide. 3. Diagnose simply. Use the Rome IV criteria and don't overtest. 4. Treat by severity. Decide if they need prevention. And 5. Educate to abort. Teach your patients to be proactive. So I'll leave you with this question. The next time a patient comes into your clinic or the ED with recurrent vomiting, pause for a second. Ask yourself, could this be CVS? With this framework, you're now ready to be the person who finally catches a diagnosis, stops the suffering, and really changes a patient's life.